collaboration between Nordica and Lagoon Hospitals will be an information and knowledge sharing event. And we believe that by the time we're done with today's event, most of us would come out better enlightened and prepared for the IVF process. So today we'll be having two very distinguished speakers. From the Nordica Fertility Center side, we have Dr. Victor Ajayi. He's the medical director and a consultant gynecologist at Nordica Fertility Center, specializing in reproductive medicine. He's highly trained in advanced reproductive technologies and has over 15 years of experience managing complex fertility cases. As medical director, he oversees clinical protocols and quality assurance across all Nordica facilities, ensuring the highest standards of patient care and consistency in service delivery. Dr. Ajayi is an alumnus of Ahmadu Bello University. He's a member of the National Postgraduate Medical College of Nigeria, Obstetrics and Gynecology, and a member of the Society of Gynecology and Obstetrics of Nigeria, SOGON. Also this morning, we have with us Dr. Omotayo Ayeni. She obtained her first degree from the prestigious Obafemi Awolowo University College of Medicine in Ile-Ife and completed her residency program at the University of Ilorin Teaching Hospital. She qualified as a fellow of the West African College of Surgeons and the National Postgraduate Medical College of Nigeria over a decade ago. Dr. Ayeni also obtained a diploma in fetal maternal medicine and a certification in assisted reproductive endocrinology and minimal access surgeries. She's a consultant and head of Department of Obstetrics and Gynecology at the Iwosan Lagoon Hospital Group. So welcome our speakers. So we don't waste too much of your time this morning. I would like to call on Dr. Victor Ajayi to take us with his paper, Innovation in IVF, How Technology is Improving Success Rates. Dr. Victor Ajayi, welcome on board.
Good morning, Mr. Honora, and to everybody listening to us this morning in Lagos, Nigeria. It's always an honor to talk about IVF, which is something I'm very passionate about. So good morning, everyone. I'll be taking us through innovation in vitro fertilization, how technology is improving success rates. My name is Dr. Victor Ajayi. So we'll get straight to it. 1 minute. Okay. So at the end of this webinar, we would hope to understand how IVF technology has evolved over the last 4 decades. Also look at major innovations that have happened over time. Also, what's the clinical impact of these innovations in terms of pregnancy and live birth rates? Also, what are the limitations of these innovations and what the future holds for IVF? Infertility, we define it as the inability of a couple to conceive after 1 year of regular, unprotected sexual intercourse. This definition basically is for women who are less than 35 years. In women who are older than 35 years, we suggest that after 6 months of trying with their partner, frequent intercourse, unprotected intercourse, and pregnancy is not happening, they should see their gynecologist at least, and probably eventually their fertility doctors. Now, 1 in every 6 people worldwide have this challenge of infertility. When we look at the possible causes or factors that contribute to infertility, we have the male factor. So sometimes the problem is purely in the man, so things like low sperm count, or even no sperms at all, we call azoospermia. And then we have situations where about 30% of the time, the problem is just in the woman, while the male partner is fine. So things like problems with ovulation, blocked fallopian tubes, uterine factors. All this can contribute to infertility arising from the female. Sometimes we have problems in the two parties, the man and the woman, which we call combined factor. So you can have low sperm count in the man and blocked fallopian tubes in the woman. And then we have about 10 to 15% where we classify as unexplained, where all the tests have been done and nothing is found wrong, but they are not just getting pregnant. Also to add that men contribute about half, 50% of the causes of infertility. So if you look at the two genders, it's split about halfway between the two of them. Okay, so what is assisted reproductive technology? Basically, it encompasses procedures, clinical procedures. The most commonly spoken about is in vitro fertilization. These procedures try to increase the likelihood of pregnancy, in a couple by manipulating eggs, sperms, which come together to form the embryos in the laboratory, which is a controlled environment. So ultimately the success rate depends on four critical areas or factors, which is the egg quality, the sperm quality, and then the embryo quality, which is formed from the egg, and the embryo is formed from the egg and the sperm. And then where we're going to place these embryos, that's the endometrial receptivity. I like to look at IVF as farming or planting a seed, where the seed is the embryo, or the embryo is the seed, and then the endometrium, the lining of the uterus, is the soil. So you need good soil, good seed for a plant to germinate. So similarly, you need good embryos, good quality, which comes from good egg and good sperm. And then where we're going to implant this embryo, the endometrium has to also be of good shape. So as the picture shows in the slide, basically it involves medications to make the woman produce eggs from her ovaries. We collect the eggs, and then the male partner produces the sperms, and we put the sperms and eggs together, and then we form the embryos, which are now transferred, as shown step 4 there, into the uterine cavity. And then we expect the embryo to implant and become a baby. Incidentally, Louis Brown, the first baby, IVF baby, was born about this time 48 years ago, 1978, on the 25th of July. So it's her birthday, So since she was born by the work of Steptoe and Edwards in the UK, so many things have happened. So many innovations in IVF have happened, and some of them are shown on the slide. In the United States, the first IVF baby, 1981, and then also freezing of egg donation, 1983, freezing embryos, transvaginal scan to monitor follicles around 1985. Pre-implantation genetic diagnosis, as it was called that time, now called pre-implantation genetic testing these days, around 1990. Egg donation in older women whose eggs cannot be used. ICSI, intracytoplasmic sperm injection, 1992. Ability to develop embryos up to day 5 or 6, what we call blastocyst culture. Able to use this much improved method of freezing eggs or embryos vitrification from 2008. And then what is called time-lapse embryo imaging. Even artificial intelligence has come into IVF now, and genomics, automation, and IVF is now personalized to that particular patient or couple. So a lot has happened over time. One of the advances is in the laboratory, where before we get to the laboratory, what we call controlled ovarian hyperstimulation, which is a stage before we get to the lab. In this case, now we can use special methods or medications, which we call recombinant gonadotrophins. Gonadotrophins are hormones that the body naturally produces from the brain to help the ovaries produce eggs. Now we can mimic these natural hormones with much greater purity and consistency. We can individualize protocols to tailor it to each patient, depending on their needs. We can have there's a test called anti-malarial hormone, which can estimate what we call the ovarian reserve. We can do antral follicle count on scans. There are scans that even do it for you without you manually counting it. The scans can estimate the antral follicle count. And then this can guide how much medication you should give the patient. And if you can do this, you can reduce the risk of a complication called ovarian hyperstimulation syndrome, which also can be significantly reduced by a protocol called the antagonist protocol, the GnRH antagonist protocol. These are things that have developed over time and have increased the chance of getting mature eggs, fertilized oocytes, that is eggs, dramatically reduce the incidence of the dreaded ovarian hyperstimulation syndrome. And now the trend is towards what we call OHSS-free clinics, which is very important. For instance, in Nordica, safety is number one, and OHSS free clinic is what we aim at. It also improves patient safety, comfort throughout the stimulation, and then greater cycle efficiency and reduced IVF cycle cancellation rates. So this is one of the advancements in assisted reproduction. Then now we can also collect eggs that are immature and mature them outside the body in the laboratory, so that it can potentially reduce how much medication we'll give patients, particularly in patients who have cancers and are trying to preserve their fertility. They quickly want to collect eggs and go and do their chemotherapy or some other treatment. And then you don't want to give high doses of medication because of the risks. People who are PCOS patients and all that. So we can, in summary, these days we can do what is called in vitro maturation, where we mature the eggs outside the body. And yes, we can still have mature eggs from that. Fertilization can also be good with embryos and, IVF successes. Yes, there's still the thinking that there's a gap between the success rate of these embryos from this method versus, the standard one. But research is still going on to try to optimize this protocol, this in vitro maturation, to close the gap between the success rate and the conventional IVF. Now, I mentioned earlier that also we can now personalize IVF protocols based on AMH, anti-malarial hormone levels, and antral follicle count, age of the patient, BMI, genetics, previous IVF response. So we can put all this information together and be able to, personalize the protocol for these patients. For sperms, we also have techniques now to select the best sperms. So there's what is called the standard one is intracytoplasmic sperm injection, ICSI, which is the common one where we look for the fastest sperm, and pick it and inject into the egg. Now we have the one we call IMSI, intracytoplasmic morphologically selected sperm injection, which magnifies the sperms under using a software so that under the microscope we can enlarge the sperms to at least 6,000 times their normal size. The ICSI machine just does about times 400, but if you can take it to up to 6,000 or more size, you can see the sperms better and you can select the normal ones and potentially improve outcomes. PICSI is another one. This is physiologic intracytoplasmic sperm injection. So the sperms are first poured in a special dish called the PICSI dish. The dish is impregnated with a substance, if you like, called hyaluronan, which is normally found in the uterine cavity around the eggs and all that. So the best sperms will be able to stick to the dish, attach to the dish. We call it binding. And then you can separate the very good sperms from the ones that are not so okay, as shown in the picture in the middle there. So they're attached to the best sperms attached to that red spot there, and then you can select from amongst those sperms to inject into the egg. These are things that can improve outcome, and studies have shown that they may improve success rates, fertilization rates, and eventually IVF success rates in men with severe male factor infertility. There's also microfluidic sperm sorting. It's a chip-based separation of sperms. It mimics what happens naturally, so it's a subtle way of selecting the sperms that is less disruptive to their DNA in particular. And this also has been shown to improve sperm selection and also improve IVF outcomes. There's also magnetic activated cell sorting to remove dead, DNA damaged sperms, which if they are used to fertilize the eggs, they can negatively affect outcome. So overall, the clinical benefits of these advanced methods include selection of sperm with superior morphology. Morphology is talking about the appearance of the sperm and the genetic integrity of these sperms. So you have lower DNA fragmentation index in selected sperm populations. It improves fertilization rates and embryo quality. And also importantly, it reduces the miscarriage risk in couples with recurrent pregnancy loss. So, because in the end, when we do IVF, we don't just want a positive pregnancy test. We want a baby at the end, a healthy baby at the end. So miscarriages are also not something we want in IVF. So this technique potentially can reduce miscarriage rates in people with recurrent pregnancy losses due to sperm factor. Okay. So these advanced selection techniques, studies have looked at them, and generally speaking, they've been shown to improve outcomes where there's severe, especially where there's severe male factor infertility. So I'll just say a little bit more about the sperm DNA fragmentation testing. It's one of the, not really new, but it's one of the innovations that came up because we used to think that when the sperm parameters are all normal, then there's no problem. You'll be wondering why this man is not able to get his partner pregnant. But it's now been shown that there's something else apart from sperm count, sperm motility, sperm morphology. It's called the sperm DNA integrity. So if the sperms have a lot of damage to their DNA, this can affect the ability to fertilize the egg, result in a good quality embryo and good implantation rates and a successful pregnancy. The reverse is that if this is abnormal, then it can lead to reduced IVF success rates and miscarriages. Okay, so studies show that up to 80% of couples with idiopathic, when you say unknown infertility, cause of infertility, have measurable sperm DNA damage. So some factors that contribute to damage of the DNA of sperm include lifestyle, which we see a lot these days, alcohol use, cigarette smoking, use of recreational drugs, marijuana, cocaine, and all that, infrequent ejaculation, aging. These are factors that affect, and BMI, increased BMI, overweight, obese people may have problems with damage to their sperm DNA, and this can potentially affect IVF outcomes. So this test, for now, it's not been agreed that it's done routinely, but in certain cases, unexplained infertility, multiple failed previous IVF cycles, recurrent miscarriages, advanced age, older men, usually around 45 and older, people who have varicocele, occupational exposures, petrochemical industry, exposures, such men can be advised to have sperm DNA fragmentation test. Poor semen parameters. It's commoner to see increased DNA damage in men with poor semen parameters. And then people who also, they did an IVF cycle and the embryo development is arrested. This is an indication to do sperm DNA integrity test, fragmentation index test. Now, how do we score it? So we say when it's less than 15%, it comes in percentages, the result. If it's less than 15%, we say the man has optimal fertility potential, excellent to good. And as it increases, the fertility potential reduces. Generally speaking, 25% and below, or less than 25%, is what is recommended. Above that, you might need to intervene clinically. and then see what can be done. And things like PICSI, microfluidic sperm sorting that I mentioned earlier may improve sperm selection and eventually improve IVF success rate. So this is one of the things that we can do now when indicated. There's also sperm aneuploidy testing. This is also to test the sperm. There's a specialized diagnostic tool that evaluates chromosomal abnormalities in the sperm. So it can directly look at the sperm and see if the chromosomes are abnormal, particularly chromosome 13, 18, and 21, and then the X and Y chromosomes to see. Some studies in the past have shown that women whose partners have a normal SAT, sperm aneuploidy testing. If you look at their pregnancy rates, it's almost more than twice the women who have abnormal SAT. So you can see 37% versus 18%. And then look at the miscarriage rate, it's almost double for people whose women whose spouses have abnormal SAT. So these are things that can affect outcome of IVF. So these are things we can test these days and take necessary action. Okay, so intracytoplasmic sperm injection, which is mostly the standard now in picking the best sperms. And then on top of that, we can do the PICSI, IMSI that I mentioned earlier when indicated. But one thing that ICSI has helped us to do is that we can pick a single sperm, directly inject into the egg. Now, particularly people with very severe male factor infertility, or people who need to get sperms from their testes. So there are situations where the man is exospermic. Exospermia means that there are no sperms at all. Okay, so when it is obstructive exospermia, that means that the problem is not coming from the testis that produces the sperms. It's probably a blockage along the way that is causing that. We can go directly to the testis in a procedure we call TESA, testicular sperm aspiration. There's also testicular sperm extraction. There's PESA, MESA, where you go to the epididymis and all that. So basically, these procedures have helped men who otherwise, if they are exospermic, maybe the next thing we'll be thinking of is donor sperm, which is not very acceptable to everyone. But now we can, despite zero sperm count, we can look at other sources of sperms and then use the ICSI method to pick the few sperms that we'll get from TESA to directly inject into the eggs that they have. Even if they have limited oocyte numbers, we can have good fertilization rates and good pregnancy outcomes. So this is one of the things that technology has helped us to achieve now. Now coming to the lab, there are high efficiency particulate air filters now in the lab that try to maintain ultra low particulate environments in the lab, because this is very important. Dust, any particles in the air, moisture, those things are very important and can, affect the processes in the laboratory and reduce IVF success rate. So we have these specialized filters now. We have, ability to control the temperatures better in the lab, humidity, oxygen levels, volatile organic compounds also. These are things that can be harmful to eggs and embryos. So technology has improved our ability to, take care of these things, and also continuous electronic incubator monitoring, automated alarm dialers when the incubator has a problem or it's in the night, no one is on ground physically. There are automated dialers that can alert the laboratory and the clinic to be able to quickly address that and still protect the embryos. So these advanced laboratory techniques or technology has significantly improved embryo development kinetics. The formation of blastocysts, has improved, reduced oxidative stress on the gametes and embryos, and then consistent reproducible culture conditions across all cycles. So you can be sure that all your cycles, you are maintaining the same situations, and this also can, improve the outcome of IVF. There's also what we call vitrification, that is freezing, ability to freeze eggs and embryos It used to be the slow freezing method, which had issues of recovery of embryos or eggs that have been frozen, compared to the more recent, not very recent, but the more recent compared to slow freezing vitrification. So it's an ultra rapid cryopreservation technique. So and this has improved egg freezing. Survival rates now exceed 80-90%. So it's very good for fertility preservation. People who are not ready to start their families, or like the cancer patients I mentioned, who can preserve your fertility. And then vitrification has come in very handy. One of the technologies that has improved IVF outcomes. Embryos can be frozen, with vitrification and used in a subsequent cycle. So people who, for instance, have ovarian hyperstimulation syndrome, you want to prevent that, PCOS patients, you can freeze their embryos, and then you can be sure of recovering a good number of them and transferring a subsequent cycle. So it reduces the risk of this complication, and it also improves pregnancy outcome going forward. I've also mentioned the positive effect on cancer management. Okay, so this is one of the things also. So we also have still in the laboratory now, time-lapse imaging for embryo monitoring. So this is a technology that can allow us, look at how the embryos are developing without having to disturb the embryo. So traditional way would be, every day you go into the incubator, take out the embryos, look at them, how they're developing, put them back like that. But with time-lapse imaging, you don't have to do all that. It's automated, and the technology can take pictures of the embryos. You can set to take pictures of the embryos as they develop, so it doesn't disturb the embryos, and then also captures precise developmental timing, the way the cells are dividing and all that. So it enables more objective, data-driven embryo selection based on how they've developed. So we can use algorithms, including artificial intelligence, to rank embryos by their implantation potential, and also identify abnormal cleavage patterns. How did this embryo develop from, when you put the sperms to day 3, for instance, versus embryo B? If you just do spot checks, you might not see the progress of development, but you can see that with this one, you can see that, okay, maybe embryo A struggled to get to the cleavage stage. This one did not struggle, and it can help you select embryos based on that, and improve your outcomes. However, some of the things we're going to talk about today, I must say, are still experimental, or the evidence is not very strong yet on using them, especially routinely. So ESHRE says that useful for continuous undisturbed embryo monitoring, and provides richer development data than conventional assessment. However, it does not consistently improve live birth rates compared to standard embryo culture and selection. Evidence for a direct clinical benefit remains inconclusive. So it's still inconclusive, so not routinely recommended. So these are some of the things that we need to take note of in this technological advancements that we're talking about. Okay, there's also pre-implantation genetic testing. Now we can take a sample from an embryo, a blastocyst, and be able to test whether that embryo is normal or abnormal. Okay, so this can help us to, for instance, people who have had abnormal babies with chromosomal abnormalities in the past, Down syndrome, they can use this method to select the embryos that they are going to transfer in their IVF cycle to take away that risk. Or people who have had repeated miscarriages, that can also, this method can help. Or people who want to do a PGTM to be able, for instance, they are both AS genotype. Now we can select the embryos and transfer only the ones that are not SS, sickle cell gene in them, and then we can now, take away that risk of SS. So a lot of things we can do with pre-implantation genetic testing, but we have to look at the cost implications and also other factors that may come in this technology. But it's available now, and it's something that IVF clinics are able to offer. Again, PGTA is a powerful tool in selected populations, so it's not routine, particularly women with advanced age, because at that age, their eggs are not so okay in terms of the chromosomes and all that, and you may want to select the best embryos for them and then reduce the risk of improve their success rates and reduce the risk of miscarriages. Okay, because some of the leading causes of miscarriages is abnormal embryos. Okay. However, for unselected routine IVF patients, the evidence does not support a consistent improvement in cumulative live birth rates per started cycle. So it's not routine. It's not recommended to be routine add-on for all IVF patients. So we need to individualize some of these things we're talking about in cases where we think they are necessary. Now also, instead of taking a biopsy, a sample from the embryo, which in untrained hands can damage the embryo, okay, if you're not well trained to do that. And now you can do what we call non-invasive pre-implantation genetic testing for aneuploidy, NIPGTA, where the culture medium, where the embryos develop, they release what we call cell-free DNA into that culture medium. So all you need is to take that fluid and it will help to give us information on that embryo. We can subject it to next generation sequencing, and we can get the chromosomal composition from that, and then it can infer the genetic nature of that embryo, whether it's competent or not. So this is also available. This is one relatively recent technological improvement, so it eliminates the biopsy risk, potential damage to the embryo, and then if the embryo is damaged at biopsy, it reduces the implantation. So also it's less, because that biopsy needs a lot of training to be able to do. So it reduces that need for specialized biopsy training and potentially applicable to all IVF embryos without additional intervention. So this is also available now. Then there's what we call the Savior sibling. So now we can also use the pre-implantation genetic testing to have another baby who is HLA typed, in the sense that you can, you want to say maybe there's sickle cell disease, there's thalassemia, you want to do a bone marrow transplantation, but you need someone who is matched to that unwell child. So a child can be born by IVF, and then it's HLA matched from the get-go, and only those embryos that are HLA matched and normal are transferred into the woman, the mother, to have that child. However, you agree with me that we need to look at the ethical considerations in this kind of situation. A Savior sibling is a child who was created with IVF and PGT in order to provide treatment to its sibling. So is this right? That's one poser to our audience and the ethical people. So these are things that, like I mentioned, these technological advancements. We have to put them in perspective of the ethical implications and whether it is right to do this thing. So they are not very common or approved to be done in everywhere. There's a lot of these things are still subject to some controversy. Then artificial intelligence, like we see in every aspect of our lives, it has come into IVF also. And AI can improve embryo morphology and selection of embryos. Help you look at the age, the AMH, BMI diagnosis, patient data, and able to help you analyze. So AI can help embryo ranking. So we can be able to say, okay, this embryo is better than that, and select the best ones for transfer. It can predict implantation. Okay. It can also the stimulation optimization, gonadotropin dosing to use. So a lot of things that AI can do, in IVF. So this is something to also note. So the use of robotics, automation in assisted reproduction is another thing that's emerging. It's one of the emerging technologies. Robotic systems for oocyte denudation. So the things that the embryologists do, robots can begin to do that. I'll make a comment on this at the end of the presentation. Even the ICSI that needs a lot of precision. If you see embryologists do ICSI, they have to be very precise. So robots may be taking over that role maybe in future. Cryo freezing, cryopreservation, also automated digital laboratory management. So a lot of things are happening technologically in the laboratory. Now, also, I think we've already said so much about data analytics and able to use all the information we have about the patient to predict their IVF outcome, what their ovarian response will be, implantation potential, risk of a condition, the complication called ovarian hyperstimulation, and this can help us personalize their protocol. So data can really help now with technology to give the best to the patient. Then in the laboratory also, there are electronic witnessing systems. One of the things I hear from our clients, some of our clients sometimes is, how am I sure my embryos will not be mixed with someone else's embryos, or my sperms and all that mixed with someone else's? People are worried about this. So with technology, there are witnessing systems, that don't depend on humans, try to reduce human errors. Radio frequency identification tags on sample containers. They enable automated contactless identity verification at every point of handling, from the point of the eggs up to the point of embryo transfer. There are barcodes that similar to what we see in shopping malls, where items that you can scan, at every point to make sure you are dealing with the same patient sample. Okay, so automated identity verification, real-time alerts, and logs that prevent the wrong sample from being processed. All these are now available and can help reduce mix-up in the laboratory. Now, we go to third-party reproduction. So sometimes the couple have issues with their eggs or their sperms. We'll have cases where it's zero count of sperms, the TISA is not an option, or going to the test is not an option, like in non-obstructive azoospermia, or the woman is much older and her eggs are not okay to use. So there's the option now of egg donation, sperm donation, even embryo donation. And then some people are unable to carry the pregnancy themselves for medical reasons, either cardiac problems, or their uterus has been removed from a previous surgery. They can have surrogacy where someone else carries the pregnancy for them. So all these third-party reproduction are also available these days. Now also there's what we call carrier genetic testing, where we can screen, some couples or even people using donor gametes, they may be worried that if the donor is carrying something that is lying quiet. Autosomal recessive is a condition that only happens when the sperm and the egg, or the man and the woman, are carrying that gene or that problem. And when the two come together, then it becomes a problem, baby. And an example is AS genotype. People with AS are fine, except they have a child together that is SS. So we also have carrier genetic testing, where you can test the man and test the woman, either a donor or his wife, to be sure that there's nothing that will match and be a problem in the child. So this is also available as one of the improved technological advancements. This is still subject to research and mostly experimental, where you can virtually be thinking you can wake up the ovaries that may not be able to produce eggs, either because of age or premature ovarian insufficiency. Platelet-rich plasma is prepared and injected into the woman's ovaries. So you can now, the ovaries may now rejuvenate and then be able to produce eggs naturally, or IVF, and then look at pregnancy. Some have reported pregnancies from this, but the actual opinion is that intrauterine and intra-ovarian PRP administration has attracted interest for thin endometrium and poor ovarian reserve. Evidence-based is currently insufficient to support routine clinical use. So the verdict is, should be offered within proper designed research trials. So it's mainly experimental for now. Again, there's this what we call laser-assisted hatching. The wall around the egg of a woman, zona pellucida, can get hardened. Okay, age is one of the causes. It can also be seen in previous failed IVF cycles, women with this, and then frozen embryos. So there's this technique that we can use to, create a weakness, if I may say, in the wall of the womb, in the wall of the egg, the zona, to help the hatching of the embryos for implantation. So again, the verdict is that it's not recommended routinely, but may be considered in select cases, but should not be offered as a standard component of all IVF cycles. So, but it's something that may improve outcome of IVF in select patients. Now, again, this is basically experimental, that where you have, they are using, the couple are using donor eggs, they are worried about the genetic material, getting, transferred to their child. They want their genetic material. So now you can, still carry their genetic material from their, the fertilized egg and transport it into the shell, the egg of a donor. And so you can still preserve their own genetic material. So again, this is experimental. This is not approved to be done routinely. There's what we call endometrial scratching. This also is the verdict by ESHRE is that ESHRE does not recommend endometrial scratching for routine IVF. It should be offered as a standard add-on without a specific evidence-based indication. So basically, the inside of the womb is scratched to improve. It releases some growth factors that may improve implantation in a subsequent cycle. So women who have had failed IVF cycles may consider this. There's embryo glue is another add-on to try to improve implantation, especially in those who have had failed IVF cycles, and ESHRE says it might modestly improve implantation rates. Evidence is still low as it concerns this. Endometrial receptivity analysis, there's the thinking that there's a special window that is best to transfer embryos. And if you miss that window, that cycle might fail. So now we can test a woman who have recurrent IVF failures. We can do this test by taking a sample from the lining of the womb and be able to detect if they are using the right window to transfer, or we should adjust it by a day or so. So this is also available. Again, granulocyte colony stimulating factor, women with thin endometrium, the lining is not thick enough. We say we want at least 7 millimeters for good implantation. If this remains a problem, then this injection can be injected into the patient, and then it may potentially improve outcomes. But evidence is insufficient, according to ESHRE, to ask people to do this routinely. I already mentioned this platelet-rich plasma. So apart from injecting into the ovaries, it can also be injected into the womb for thin endometrium and to repair the lining of the womb and potentially improve outcomes. Also, the overall evidence is still weak, and these are things that are emerging, and further research will help. So as we summarize, emerging technologies in ART, we've talked about the non-invasive PGTA and transcriptomics, where we can profile embryos and endometrium, and you see where, optimal time of synchrony, and then that can inform our transfers, AI, and all those things we've mentioned before. But we will have to also look at what are the challenges of these innovations or this technology. Cost. A lot of time, especially in this part of the world, people pay out of pocket for IVF. So you have to look at cost implications, whether it's worth doing all these things versus the cost implications. Ethical considerations. I mentioned the savior sibling factor. We need to look at that. Data privacy. If we're taking anything to AI and online, the availability of this technology, again, they are expensive. They can be expensive, and not all IVF centers will be able to do this. Then evidence is not robust at this point. A lot of the evidence is still weak, and we will need to get more evidence before we can routinely advise this thing. And then the risk of over-reliance on artificial intelligence. So the future, we think that fully automated IVF labs, real-time AI decisions, digital twins is like creating a copy of that patient, and you can use your computers and all that to simulate what will happen in real life before you even begin the IVF on that patient. So you can look at how to modify their treatment virtually before you start the process. We've also spoken of non-invasive genetic testing, and also there's precision reproductive medicine. So, in conclusion, technology has transformed IVF. There's no doubt about that, and has improved success rates from what it was before. Also, personalized medicine is replacing standardized protocols. So these days, it's not one size fits all, or one protocol fits all. We personalize our individualized protocols. Artificial intelligence also has come in with the time-lapse imaging and all that. Future innovations must be evidence-led and patient-centered. The field of ART continues to advance at an extraordinary pace since Louis Brown was born 48 years ago. But we have to, the ultimate measure of success remains unchanged. A healthy live baby taken home by parents who longed for one. So every technological innovation must be assessed against this standard through rigorous evidence, ethical scrutiny, and patient-centered counseling. As we move toward the era of automated labs and AI-guided protocols, genomic precision, we must remain vigilant that the pursuit of technological sophistication does not distract us from our primary purpose or inadvertently lead us down the ethical contested path toward designer babies. We don't want a situation where people can just go and say, okay, I want a blonde haired, blue-eyed, green-eyed girl, so we have to be careful of this, and eventually what we want is a healthy live baby at the end and a happy couple at the end of the IVF process. Thank you very much for listening. These are some of my references, and I'll be happy to take questions.
All right. Thank you very much, Dr. Ajayi. For the benefit of everyone on the call, I would like you to please go to the chat box and put your questions so that we can crash the time. We'll go into the second presentation shortly. Then we will take all the questions together, and then we'll have a kind of wrap up from both speakers. Then we can call it a day. So thank you very much, Dr. Ajayi. We are very excited to all this innovation. I'm afraid that very soon we go to the hospital, we won't see Dr. Victor Ajayi in the hospital, we'll see a machine. And the machine will ask us questions and we have to answer. So, but it's the reality of everything. It's affecting all industries. So we should just all be prepared for it. So it means that we retool ourselves. That's really the call for everyone on the call. At this juncture, I'd like to call on our second speaker. I introduced her while she was in transit, and I'd like to call on Dr. Omotayo Ayeni. She will be talking to us about IVF pregnancy, the risks and management. Dr. Omotayo Ayeni, please join us on the call right now.
Thank you, Mr. Moloko. Good morning, everybody. Can you hear me, please?
Yes, we can.
We can hear you.
Thank you.
We can hear you.
Okay, so I'm waiting for my slides to be shared. Thank you for the privilege to discuss at this beautiful webinar. My name is Dr. Ayeni, as you have been informed. And thank you, Dr. Ajayi, for that professorial discourse. It was a beautiful one. Thank you. So I'll be discussing IVF pregnancy, the risk and the management involved. Dr. Ajayi has spoken quite a lot about some of the risk and how technology has advanced to mitigate against this risk so that we can have better qualities of babies. So I am a staff of Iwosan Lagoon Hospitals, Pardon me if I quickly take our vision and values, which we are a consistently patient first, world-class healthcare services provider, we are empathetic, ethical, under-engineering and innovative and accessible, and our brand promises that we live. So I'll be discussing important this, and I can't overstate it, but I think Dr. Ajayi has stated it before, that IVF and related assisted reproductive technologies are responsible for about 2 to 9% of all births. So if you look at the global birth rate, nearly birth rate of 140 million, you know that about 2,800 babies to 2,800 million to 12,500 million babies are born from IVF annually. And we as obstetricians, we classify IVF pregnancies as high-risk pregnancies because of the complications that are linked to that kind of pregnancy. I don't want you to get me wrong that, okay, because it's an IVF pregnancy, they are different babies. No, it's essentially the same baby. But because of some other conditions, which we see as we progress, we classify it as IVF, as high-risk pregnancy. And the emotional, the mental, and the financial implications of an IVF pregnancy. We actually want us to also classify it as an IVF, as a high-risk pregnancy, and it's a pregnancy that you need to call on so that you can have a good outcome. These complications have been found to affect the pregnancy outcome and the take-home baby rate. Ability to have a live baby in your hands, which is a good, healthy baby to a healthy and satisfied mother, which is actually the goal of any good antenatal care. So, what are these risks? These risks may be related to the maternal age. Mostly older women from actually go for IVF in our own environment. Most of these women are more than 35 years. And it's at that age that you have complications, medical complications of medicine, you have issues with hypertension, diabetes, some autoimmune disorders, and also the chromosomal abnormality. Then this risk may be considered itself. Dr. Ajayi spent some time talking about ovarian hyperstimulation syndrome. And so as we go along, you see that some studies have correlated the outcome with if OHSS happened or not. The risk also of congenital abnormality, we still elaborate on this more, but he also mentioned a lot of things that is done to reduce the risk. That's why he was talking about non-invasive PIGD, the one that you have to, if you want to do biopsy, that the blastoma is not damaged. We talked about it. And multiple pregnancy. Multiple pregnancy when you have more than one baby occupying the uterus at the same time. There is on its own is associated with a lot of issues. Then you now have higher other multiples. You have the triplets, quadruplets, quintuplets, and multiple pregnancy itself is associated with increased congenital abnormality. Because of the division, especially when you have the monochorionic twin. That means the identical twins, the ones that is one egg that divided into two, that's the one we are talking about. And people who are getting pregnant for the first time, even first pregnancy on its own is a high risk pregnancy. If you talk of when an older woman that's more than 35 years is start getting pregnant, then the cause of the infertility. And a lot of people will have fibroids. That was the background of the infertility. Some will have endometriosis, some will have a lot of additions. So let's look at them one by one. We are talking about the procedure now. Ovarian hyperstimulation syndrome. Dr. Ajayi has talked about it a lot, so I will not be repeating myself. And you see that it's the one that is mild happens about 20% of 5 year cycles, the one that is moderate 2 to 6%, the one that is severe is about 0.2 to 2% of all cycles. So a study that was done by Anna et al. Was trying to look at outcome of pregnancy, the complications that may occur in that pregnancy if the woman has OHS, that the ovarian hyperstimulation syndrome. And he was able to find out that there was an increased rate of placenta abortion. That is the premature separation of placenta from the wall of the uterus before the baby was delivered in the IVF pregnancies. The other factors, yes, these are complications of IVF pregnancies, which we still discuss, like recurrent birth, preeclampsia. They were also present, but the one that was significant was the placenta abortion. So if a woman had an OHSS in pregnancy, during the IVF procedure, then as a doctor, you need to watch out for placenta abortion. Then let's look at the procedure again. We look about congenital anomaly. Studies have shown that there's an increased risk of having that is birth defects, 4.2 to 6% in women who have had an IVF procedure compared to 3 to 4% in women who did not have IVF. And this will be as a result of the underlying infertility. Dr. Jain spent a lot of time talking to us about the sperm issues when we were talking about fragility index, DNA analysis. And if you do IVF, you will realize that it's not all sperms that looks normal unless you have done a higher, you've seen them under higher technology. You know, I am magnification. That's when you know that, oh, this sperm has an issue. And this one necessitates doing procedures like intracytoplasmic sperm injection, and you have to take sperm and inject into the egg itself. Sometimes they have to do a higher one that we say intracytoplasmic morphologically selected. They have to look at the sperm very well to look at the best one, especially in men who do not have good sperm count. When they say we have low sperm count, some people have very, very low sperm count, that the count is less than 5,000. You know, they have to check and check. And in those sperms themselves, when you check the fragility, you check their mutilation, you check everything, you discover that they themselves, they have a problem. And they may also account for congenital abnormalities. So also the eggs of the woman. When the woman is older, you know, more than 35 years, you know, like Down syndrome and other chromosomal abnormality occurs in older age. So you also have the frozen oocyte cycle. When the eggs are frozen, we have two types of food that you can freeze. You can either freeze the embryo or you freeze the egg. When it is the egg that is frozen, then the eggs are arrested in what we call the second meiotic phase, the prophase. And you know, if you've seen a spider web, what is inside the egg is like a spider web. And in the process of freezing and then thawing it to use the again, there can be damage to these eggs and they can increase the risk of an abnormality. So that means it also depends on who freezes the egg for you and their technique. Then some studies have shown that fed cycles have increased risk of congenital abnormality than frozen embryo cycle. I'm sure Dr. Jai will be able to answer this one very well because I tried to look for the reason I didn't see. And of course, we talk about multiple pregnancy. And in the process of division, they can have some defects in an improper division. So a study was done and looked at about 2,351 IVF cycles and compared them to, I would also add cytoplasmic sperm injection and compare them to other pregnancies, people who had infertility, but they got pregnant spontaneously. They now found out that there was increased rates of major congenital anomalies in people who had IVF compared to the same infertile couple who were able to have babies to get pregnant spontaneously. That means a higher incidence of major congenital anomalies in IVF babies. But there's another study that was done by Hannah et al. That said that when they look at twin pregnancy, compared to the spontaneous one, there was no significant difference in major or even minor anomalies, but that was twin pregnancy, not in the singleton pregnancy. So let's look at the age of the woman. I hope you can hear me, please. Hello?
We can hear you.
Yes,
we
no,
can
we
hear
can
you.
hear
Thank you, thank you, thank you. Okay, so when we look at the age of the woman, we have talked about increased incidence of medical complications as the woman ages. That's when you have chronic hypertension, you have diabetes, you have autoimmune diseases, SLE, you have all sorts of things. And that is one of the things that can cause a complication in pregnancy because you have to manage these medical conditions. And I will talk about primary capital being a problem. We're not talking about elderly primary capital. Woman is more than 35 years, you know, and even some of them may not even be hypertensive, but studies have shown that they just become hypertensive because the process of IVF, especially if you are using a frozen embryo, they felt that okay, the placenta is not able to implant itself very well and spread its natural signals of conception and may have an increased risk of hypertensive disorders in pregnancy. For diabetes, it's called, we have to support, we have to give progesterone and estradiol because it's to support that pregnancy so that the baby doesn't just die inside because it's the ovaries that produces it in a normal pregnancy, but we have to supplement. These drugs, they can serve as insulin resistance and increase the risk of gestational diabetes. We have talked about a human being older, and if she's older, if our own egg was used instead of a donor egg, there can be increases of congenital anomaly, which is related to the age of the woman, and that one can lead to increase in the number of miscarriages. And abruptio placenta on itself, apart from the fact that you have OHS, as we have mentioned before, the increased age of the woman is a risk factor for abruptio placentation. So there was a study that was done by Pingu et al., and they correlated the increased incidence of preeclampsia and the women who had IVF. They look at the age, and we know as you go older, you also become a little bigger in size. And they discovered that there's an increased risk of preeclampsia and preterm birth in women who have an IVF pregnancy. So there's another one that they also look at increased incidence of gestational diabetes in women who had an IVF pregnancy. This is also by Pingu et al. And they discovered that there is actually no increase in significant difference in women who are more than 24, who are already in the obese range. However, in people who are smaller than that, there is an increased risk, and we just explain the reasons why they can have that. So we also look at preterm birth. Preterm birth in IVF pregnancy, not because of the IVF. Why should the woman who have an IVF have the preterm birth? Because you have multiple pregnancies. You have twins, triplets, quintuplets, and we know that it is double or triple of what the normal uterus will carry. So there's increased risk of preterm delivery in this set of people. And because of what we call the uterine threshold, and also because of the pregnancy. And the joy there is that they're always 2 weeks ahead of their fertility counterparts. There can also be increased placenta abnormality that will, because with multiple pregnancies, you can have you can have a placenta previa. And that woman, because this woman is bleeding and bleeding and bleeding, once you're able to get to the family, they want to deliver them early. Then some of these medical disorders that we've talked about, hypertension, diabetes, SLE, thyroid dysfunction, may also complicate the pregnancy and may necessitate early delivery of these babies so that we can save the life of the woman. Fibroids too, there are some fibroids that will just trigger preterm delivery and woman will go into contractions, and that one can also be a cause of preterm birth in people who have IVF. So there's a study that was done that they wanted to look at how IVF is related to increased risk of spontaneous preterm birth. That one is not caused by any decision to terminate, and they discovered that the number of women who are likely to deliver before 34 weeks is higher in women who had an IVF pregnancy. So let's look at placenta abnormalities. We have talked about abruptio placenta. Abruptio placenta, we have related it to OHSS and also the age of the woman and also hypertensive disorders that can occur in pregnancy. Then we talk about morbidly adherent placentation. This is when the placenta impedes the wall of the uterus, it penetrates the wall of the uterus because there's an absence of a layer that we call the metabolic layer. It's supposed to be there too, so that when you want to remove the placenta, you can remove it easily. But this one, it is difficult to remove. And why do we have it IVF pregnancy because of the underlying problem. So people have fibroid, they've done repeated fibroid surgery, and and the vascularity of the uterus has been compromised. Some of them is endometriosis that they have, and it has compromised the vascularity of the uterus. So it increases, and it may present with placenta as placenta previa. And some people will not even present with any placenta previa. In fact, I've had a patient that it was a twin delivery IVF pregnancy, and just to deliver the placenta, we saw that the placenta has penetrated into the uterus. She has done 2 previous myomectomy before. We talk of placenta previa. Placenta previa is when the placenta is before the baby. When the placenta is before the baby, that is placenta previa. And because it is occupying the lower segment and is close to the cervix, the woman will just be bleeding and bleeding and bleeding in pregnancy. And that is one of the things that, and why? Because the woman has done previous procedures. Endometriosis is also a risk factor. Then multiple pregnancies is a risk factor in these women. Then fibroids and endometriosis, after about previous uterine procedure, they can increase the risk of all this abnormal placentation. So a study was done by Fenkor et al. And they tried to look at placenta abnormalities and complications in patients who have had IVF in China. And they discovered that there's an increased risk of both placenta previa that I have to discuss about. That placenta accreta that you are seeing is the morbidly adherent placentation, even abnormal morphology of the placenta, and pregnancy-induced hypertension in women who have had IVF pregnancy. So there are so many more, but Dr. Jaya has done a lot of work. And as he was talking about the things he were to do, those are related to IVF, he has told us about the solution. So I'll just go to, okay, the woman is already pregnant. She has come to me. What do I do? That means we have to take a detailed history. We have to give us all your information, the things you have done before, everything. Have you done a procedure before? From the way you talk, we know what is happening, how many babies are there. And we talk about patient-centered antenatal care. So it is not, okay, this is the way the antenatal care is supposed to be. Oh, I see you every 4 weeks. No. What is the peculiarity about that patient? Because from the issue, we know if the woman is hypertensive, if she is diabetic, and you'd have also examined, you've run your investigations, we'll do a scan to know how many babies are there, we'll do other tests that are related to the pregnancy, we'll know if there's autoimmune, because people who have autoimmune diseases, they also, apart from the risk of miscarriage, they also at increased risk of unexplained intestinal fetal death. So you want to you want to be sure of that history and also provide a patient-centered antenatal care that is individualized to the care of that patient. Dr. Jaya has talked about implantation genetic diagnosis. That's to reduce the risk of the congenital abnormalities. And he also talked about the cell-free DNA, which is non-invasive to check even before the pregnancy is confirmed to rule out congenital abnormalities. So some people say, okay, what if I didn't do that and I'm pregnant already? What would I do? There's also, you can actually do it before 13 weeks of pregnancy. When you are pregnant already, then if we see any abnormality in that test, we can also do the invasive. We can do amniocentesis. We can do what we call the coronavirus sampling to check, okay, what is the problem with this baby? And other things I also want to mention is the low-dose aspirin. Low-dose aspirin has been found to be very, very useful in the prevention and the management of a lot of obstetric disorders. When we talk about abortion placenta, when we talk of hypertensive disorder in pregnancy, when we talk of unexplained intrauterine fetal death in patients who have gestational diabetes, who have autoimmune disorders. So it has been found to be useful. Folic acid. Folic acid has been found to reduce the incidence of recurrent congenital abnormalities. Apart from the fact that it's useful in blood formation, it has been found, but there's a clause to this because we also have fibroids in Africa. And when you gather about 100 African women, about 80 to 90 of them, we have fibroids. So our folic acid is the food for fibroids. So what is recommended for one pregnancy is 400 micrograms, 2 pregnancies, 800 micrograms. So you must know the amount of folic acid you are taking. It's people who have had recurrent congenital anomaly that you can give that 5 milligrams of folic acid that we give to. So you must ask your doctor which one dosage of folic acid is good for me. Is only pregnant care good alone? Alone is good for me, or I need to supplement it. Your history will make your doctor to know what to do. Then we talk about intentional screening for medical disorders. So when we talk about from examination you check the blood pressure. From examination you check the patient that is sickle cell, that has a sickle cell disease. From examination you'll be able to, when you examine the abdomen, you'll be able to check if the fibroids. You will see if there's a scar, and you'll be able to ask the patient, even if she forgot to tell you. Then from examination you'll be able to know how many babies you have. Then you do screening. We have talked about the NIPT, we have talked about coronary sampling, amniocentesis, there's a need. We have talked about looking for gestational diabetes. There are so many Doppler studies too that can predict hypertensive disorder, especially the artery Doppler that can predict the risk. And there's so many some other chemical tests that are not really available in Nigeria, but can give us an idea that this woman may develop hypertensive disorder in pregnancy. So we also talk about antenatal fetal-maternal surveillance. So that means you have to look. Fetal means the baby, maternal is the mother. You want to be checking them regularly. You want to be looking for problems. We have Doppler scans that can check the arteries of the babies and check, is there going to be a problem? Okay, is this baby, is there going to be a problem with the baby in the next 5 days, in the next 2 weeks, in the next 10 days? We talk about middle cerebral artery, we talk about the umbilical artery Doppler studies. And for the mother too, you want to see her, you want to be checking her blood pressure. If it's hypertension, you want to be checking the blood pressure. If it's diabetes, you want to be checking the blood sugar. If it is hypothyroidism, you want to do the thyroid function test. And whatever it may be, you need to see the woman more frequently in clinic and know what to do for this woman. There are some babies that are also, even if the IVF procedure was fine, there's no congenital anomaly, but there's increase of cardiac defects in these babies. These babies are babies whose mother have gestational diabetes or even pre-existing diabetes, or babies whose mother develop pre-eclampsia in pregnancy. But most of these problems can be resolved. And we have talked about even congenital anomalies associated with babies who have IVF. So we can actually do fetal echocardiography to check these babies and be sure that there is no cardiac anomaly that will need attention as the baby is born. So we also talk about birth preparedness and complication readiness. You need to prepare. How will this baby come out? What are the complications associated? Is there any complication at all? There's nothing to worry about. It will determine the route of delivery and the timing of delivery and what you need to tell the couple, and also what the couple needs to get ready. That's what we now lead us to complication readiness. Okay, if the woman has a morbidly adherent placentation now, I need to plan, because that means I may need to do an hysterectomy. So I must have the good enough skills to be able to save the life of that woman. Like the one I told you, we have to do a hysterectomy. And do we have blood transfusion services? So that will now lead me to the delivery. How do you deliver a baby that you think that the mother has a complication in an IVF pregnancy? You have to time the delivery, because the timing of delivery, you must be able to have a live and healthy baby and a live and a satisfied mother. So you must know from your knowledge that this is the appropriate time to deliver this baby to save both mother and baby. Then we have mentioned about complication readiness. Complication readiness, the skills to deliver this woman. Then if we also have to have NICU services ready. We talk about prematurity. How will you manage these babies if they are born preterm? So that means NICU services should be available. And blood transfusion services, if you need to give blood. Especially we talk about placenta previa, morbidly adherent placentation, abruptio placenta, we must have blood ready. There must be no story. And there are some others that we also need our other colleagues to manage for us. The other doctors, with the diabetic doctor, the hypertensive doctor, the rheumatoid doctor, because the woman has other issues that only the gynecologist may not be able to manage. Sometimes hematologists, sickle cell patients, Also, people who develop blood clots in pregnancy. So, in conclusion, why IVF pregnancies do require a closer observation and management? Because of all these stories we have just said, most of the time, they result in delivery of a healthy baby or babies, if we have multiple pregnancy, to healthy and satisfied mother. What is the key? A detailed, focused antenatal care that is backed by evidence-based management. At least this is what you are doing, this is what the book says, this is how to go about it. We give the above result that we have just discussed. Thank you, everybody, for listening to me.
Thank you very much, Dr. Ayeni. That was a very fantastic presentation. I hope everyone in the room has been taking notes. We have the opportunity now to go into our question and answer session. I see a hand coming up. I see a hand coming up. But just write your questions in the chat room, and we will take the questions from there. Thank you very much, Dr. Ayeni. Thank you also for all the wonderful things you do for the women at Christ Church. Thank you very much.
Thank you, Mr. Muloko.
Yes, ma'am. Thank you very much, ma'am. Let me start with one of the very early questions. I can see one here. It says, does sperm morphology reflect the status of sperm DNA fragmentation, or it is not always related to it? Dr. Victor Ajayi, can you help us with that question, sir?
Yeah, thank you very much. It is not always related to it. You know, I mentioned that, in fact, we have seen cases where the parameters are all good, but the sperm DNA integrity or damage is there, significant. So, but studies have shown that men with poor sperm parameters or poor morphology and so on have a higher chance of having also sperm DNA damage. So there's some form of relationship, but it doesn't always mean that because the morphology is abnormal, then you're going to have high DNA damage. But they're more likely to have high DNA damage in people with poor birth semen parameters, including morphology. I hope that helps.
All right, thank you very much. Another question. Is there a technology that would allow infusion of acceptor DNA into donor eggs or sperm? Is there a technology that could allow infusion of acceptor DNA into donor eggs or sperm?
Okay, so it's largely experimental, but maybe not exactly the way you've coined it. So there's what is called the mitochondrial replacement therapy. So if you want to preserve the DNA of the couple to transmit it to the child, okay? So they are going to use donor eggs. So you can create an embryo from the man and his partner's egg and sperm. Then what is called the nuclear DNA, the nucleus that has fused together, can be removed from their embryo, the shell, so to speak, and now put in the egg, the shell of a donor. In that case, the donor's mitochondria, what we call the mitochondria, the energy house, is intact, but this woman's own is not so intact, maybe because of age and all that. So that technology exists, but again, it's controversial, it's still experimental. It is what I think I showed in one of the slides, what you call the 3-parent baby. So because people sometimes are worried that, okay, when you do a DNA or the child it will not match if you are using donor eggs. So this technology allows the DNA of the couple to still be in the child, okay, even though they've used donor eggs. So it's called mitochondrial replacement therapy, mostly for women whose DNA, the mitochondrial DNA is not okay or function is not okay, but their own nuclear DNA is fine. Okay, so that is possible with technology, but it's still experimental.
All right. There's a question on there's a question sorry, there's a question on can a partner without a marriage certificate participate in IVF?
Yes, very well. Single people can do IVF. Well, sometimes it depends on what exactly you're doing. So for some kind of IVF where you want to do surrogacy and all that, you may be asked to be legally married to be able to do IVF. Some centers, that's what they recommend. But the regular IVF, yes, you can be single and do IVF. So you may want to use donor sperm if you don't have a male partner. So so it's possible. You don't have to be married or have a marriage certificate. Yeah.
Fantastic, fantastic. There's another question. In cases where donor eggs are used for IVF, how possible is it for the gynecologist to have detailed history of the egg donor, especially egg donor, in order to manage the pregnancy effectively, especially if there was OHSS during egg collection?
Okay,
Let
well,
me take it again.
okay.
It says, in cases where donor eggs are used for IVF, how possible is it for the gynecologist to have detailed history of the egg donor in order to manage the pregnancy effectively, especially if there was OHSS during egg collection?
OHSS, ovarian hyperstimulation syndrome, happens in the person who produced the eggs. Okay, so this woman who has used donor eggs is not going to have OHSS. So there's no relationship in managing her own pregnancy. Okay, so it's the donor that's going to have the donor that is stimulated with IVF drugs that may have this OHSS, and she'll usually be fine when she's managed. So there's no need to have any, it doesn't impact on her own pregnancy because she was not stimulated, so she's not going to have OHSS. But every good clinic usually will have history of the donor just to answer the question holistically. Maybe that's another part of the question. History of the donor is always sought. Family history, risk of medical conditions and all that. So it's available. People who use donor eggs can request for that history, and if they want to share with their gynecologist, it's fine. But it has no impact on she will not have OHSS because she used donor eggs. Okay.
Fantastic. Another question. A couple who have had 3 failed embryo transfers, 2 of which are via surrogacy. One of the surrogates had a chemical pregnancy, no heartbeat. What do you advise as the next step?
Okay, she's had, did I get that right? 3 failed attempts?
3 failed embryo transfers, 3 failed ones,
Okay,
2 of which are via surrogacy.
Yes. So when you get such recurrent miscarriages or IVF failures or blighted ovum and all that, you also need to look at the embryo, okay, which comes from the egg and the sperm. So when we need more details, how old is the person who produced the eggs? Because as women get older, also the chance of their eggs being abnormal is higher. The age of the sperm, what are the sperms like? Bottom line is that you may need to consider genetic testing on the embryo because it might be a factor in repeated IVF failures and miscarriages. So the stronger factor in the egg and the uterus are very important in IVF success, but usually the stronger factor is the embryo. Okay, so it's not necessarily the problem with the surrogates, though it's important to check the womb and make sure it's fine. So what I would suggest is that she has a review with her doctor to see these features, these things I mentioned, egg quality, sperm quality. She may need to consider testing the embryos before a subsequent transfer, pre-implantation genetic testing.
I think that, madam, whoever sent that question, please avail yourselves of the specialists available here today and take the right decisions to be able to take us to our promised land. One more question. It says, what is the age limit to have IVF, knowing fully well that advanced age has its own demerits in this setting? So something about
Yes. Age limit is usually subject to the clinic or the regulatory bodies that govern assisted reproduction, depending on the country and the authorities. So some will say around 57, thereabout, some will cap it at 60. The important thing is that people want to prevent, as Dr. Ayeni mentioned, as women get older, they normally have medical conditions also becoming more prominent. And again, I remember, I think there was a client abroad that had embryo IVF at about 70. She died shortly after that. I think she had a cancer or something like that. So these are things that we look out for to determine the cutoff age. So we are careful the older the woman is because of these medical conditions that can be there. Also, the energy, if you like, to take care of babies at that age. Is it ideal for her as herself and the children that you are bringing in? So yes, 57, 60, some will cap it at that age.
For everyone, the one question is PGT done in Nigeria?
Yes, PGT is available in Nigeria. It's available. Many clinics do offer pre-plantation genetic testing, but of course, you must be sure that they are good at it, because the freezing of the embryos, because embryos usually have to be frozen. The biopsy, I mentioned that it's a specialized technique to have an embryologist who can take a good biopsy without harming the embryo. So genetic testing is available in Nigeria.
All right, fantastic. Are there more questions from the floor? We have more questions before we take both final words from Dr. Ayeni and Dr. Ajayi. Okay, thumbs up from Fatima Odushote. Okay, mitochondrial replacements, fantastic. Big takeaway from that. Okay, no other questions from the floor? Let's see, 1 minute, 2 minutes. Well, I think most people they are shying. I wish it was okay. Good. If someone is anemic, does it affect IVF? If someone is anemic, does it affect IVF?
Okay, so basically it depends what level of anemia we're talking about. So people with anemia can get pregnant, right? Even naturally. But you don't want anemic patients going into such sometimes a bit rigorous process, and then the pregnancy itself. I'm sure Dr. Ayeni will agree that you don't want a patient getting pregnant while already anemic, because pregnancy has its own demands on the blood supply, heart function, and all that. And we've also said that there's a high chance, increased, let me not say high like that, but increased chance of multiple pregnancy when you do IVF. So it's best to optimize such a patient. Make sure you correct anemia before you start the process. Just to build up on that question, Dr. Ayeni mentioned the several things that have been linked to women who do IVF, the outcomes, their babies and themselves, But what is important is to evaluate your patient before you start IVF. So for instance, in our clinic, if a woman is 45 years and older, wants to do IVF, there's a comprehensive checkup that is done before she starts, because things like hypertensive conditions, diseases, diabetes are common at that age. So you don't want a patient with any background situation going into IVF without correcting it, full blood count, all these things. So if there's anemia, you pick it before they start. If there are fibroids that need to be sorted before they start, we also advise they are sorted before they go ahead, because fibroids can affect the outcome sometimes, can also lead to these miscarriages or premature labor in pregnancy. So bottom line, we won't advise a woman with anemia, especially if it's significant, to start the process without optimizing it. It's better to take care of that before starting the process.
Now, just another question. Some questions have just come in. Is it safe for a surrogate mother with a negative blood group to carry a pregnancy? Is it safe for a surrogate mother?
Rhesus negative. Okay, so if she's rhesus negative, one would not advise that, because a rhesus negative mother or woman could have, especially if she has had a child before, or some situation where the blood of the child she carried has gone into her own blood. So if she carried a rhesus positive child in the past, during childbirth or even pregnancy, the blood from that child can leak into her own blood. Okay. Now, because she's rhesus negative, she produces what we call antibodies. Antibodies are like soldiers that fight the foreign blood that has entered her. Because she's rhesus negative, she doesn't have positive blood. It has come into her. They damage they kill off those positive blood that has come in, but they remain behind. So that the next pregnancy, if that child is also rhesus positive, those soldiers, those antibodies will fight the child's blood and can cause anemia. The child can even be lost in the uterus of that woman. So a rhesus negative donor, one will not generally advise that to carry a pregnancy because of this risk.
Okay. Now, for a donor egg IVF, won't it affect the DNA or genetic makeup? This came from Facebook a few minutes ago.
Yes.
For donor egg IVF, won't it affect DNA?
Yes. So the way to explain it in layman's terms is that if you use donor eggs and you do a DNA test, the woman, your DNA will not match the child's one. Okay. So that's the thing. I'm explaining this mitochondrial transfer thing and that's a concern for some patients that, okay, if I use donor eggs, if they do a DNA, it won't match, and I have concerns about that. So yes, it will match, but if you do it with your husband's sperms, it will match your husband's sperms DNA, but it will match yours. That's the regular IVF with donor sperms. Yes.
Please, for the endometrial PRP, at what time should we do it before frozen transfer?
Okay, so there are a number of protocols. Some will do it just on the day of trigger. Those who are using their eggs, they are stimulating on the day of trigger. You infuse it in, and then you do your transfer. That's the commonest protocol that is used. Some will do it after the endometrium is ready. You've done the 13 scan is ready. You're preparing for transfer. For those using either donor eggs or frozen embryos. So yeah, there are a number of protocols, but those using their own eggs, usually at trigger, then you infuse it and then plan your transfer day 3 or day 5, depending on what transfer you're doing.
All right, fantastic. I think the questions have frozen, but I would like to give both Dr. Victor Ajayi and Dr. Ayeni 1 minute to a piece of advice to everyone who has been listening this morning. What would you, Dr. Ajayi, what would you advise anyone? I think it's important that after listening to this, what would be the next step? What should be the person's next step?
Okay.
I think one more.
Okay.
Okay. Good. All right. Go ahead, sir.
Well, that it's been very interesting talking about IVF and innovations. Just to say that it's very important that if you are listening to this and you have the challenge of infertility, you've done IVF cycles and it's not worked before. There are innovations that can potentially improve your outcome. So seek a good hospital, a good clinic, IVF center with experience in these things. And then you can possibly improve your chances. Yes, some of these things may be more expensive than regular IVF. And we also, as practitioners, should not throw everything in just for the sake of it, because it has to be cost effective and indicated before we do that. But I also want to advise people not to look at costs in making decisions. So the important thing is that people should go to the right hospitals, and also any procedure that's being advised, you have the right to ask questions. What is the reason why you are doing this for me? Is there any indication? Because practitioners must also not just put so much demands financially on clients when there's no reason to do these procedures. And then, as I said in my concluding slides, that a lot of these things are still experimental. And also, we must not get to the point that we want to form designer babies. We should focus on the main thing that IVF wants to achieve, to help a couple, the long-suffering couple that have been trying to achieve conception. I think those are my final words.
All right. Dr. Ayeni, your parting words for everyone.
Okay, thank you everybody for coming for this webinar. We appreciate you all. And IVF pregnancies have revolutionized the world. A lot of people who thought they could not have babies now are joyful mothers, and that is very encouraging. IVF pregnancies and babies are normal babies, healthy babies. And for people who have doubts about donor egg, surrogacy, technology has advanced so much that everybody can be happy, and you don't need to delay it. It's not only when you are old and you have these complications that we are talking about, that is when you'll be looking for one. It is time to act now so that you can spend a longer time with your children and be happy. Another thing is that you should not be afraid of your pregnancy. There are advances in management that will give you your desired outcome, which is a healthy and a live baby, and you to be healthy and satisfied. Have a lovely weekend, everybody.
Sorry, just before we go, Dr. Ajayi, someone just sent a last-minute question. It says, please, what are the comprehensive tests that needs to be done for a surrogate mother before transfer embryos to her? That what tests should they carry out on a surrogate before they transfer?
Okay, for tests, I would also start from, in medicine, we talk about history, physical examination before laboratory test. So she needs to be asked questions. Has she been pregnant before? Has she carried a pregnancy successfully? All that family history of medical conditions, diabetes, hypertension, even in her, does she have those histories? Has she had surgeries before? So this is part of the screening. Examination, a scan, and then there's a check of the inside of the womb, where the baby is going to grow, where the embryos is going to be implanted. It's very important to check that. In terms of laboratory tests, the basic test will be the infectious disease screening, HIV, hepatitis, all these infections that can be transmissible to the child when she's pregnant. We have to screen for that. Then someone asked correctly, the blood group is very important. Genotype is not a major factor. It won't be transmitted to the child, even if she's AS, but you won't want an SS surrogate to carry pregnancy because of the risk of crisis. So these are the key things that you need. Check the womb, then those blood tests, and then the questions also from history and examination, your scans. And then once she's fit, then she can now proceed.
Dr. Ajayi, sorry I think the questions are now coming in a little.
No problem.
But let me just take this one. Let me take this one. If the rhesus negative claimed she took anti-D gamma globulin injection, can that be confirmed through a blood test? The question about the surrogate,
Yes. Coombs tests, indirect Coombs tests can be done, to see whether she's sensitized or not and all that. But I'm happy you said claimed, sometimes it's better to just, go on, because the anti-D it will help, but might not be foolproof, so to speak. might not be foolproof, and they are not sure whether that happens. So even the test you need to do, that is extra resources you are spending on that. And so to be certain, it's better to avoid rhesus negative surrogates, because you're going to spend a lot to do a surrogacy treatment. So it might better to get the surrogate with no commas, if I may use that phrase, and then so you don't have any issues.
Thank you very much. For everyone on the call, I'd like you to follow the two phone numbers for Iwosan Lagoon Hospital. Here we have 0708 060 9000 and 0708 639 3027 for your phone calls if you want to talk to Lagoon after this webinar. And also on WhatsApp, you can send WhatsApp messages to 0913 938 3474. And you can follow Nordica Fertility Center on all their social media handles, Nordica Fertility, on Facebook, Instagram, LinkedIn, and you can also visit any of our centers in Ikoyi, 106 Norman Williams, 38 Jalukmo Crescent, Sulere, Abuja, Queen Elizabeth Street in Asokoro, and in Asaba also. So please take advantage of all the experts services are available at both hospitals. And I trust that for those of us trusting God for children, very soon, with the help of God and the help of science, this joy will fill our homes. Thank you for joining us today. And when next we call, please oblige us with your presence and invite other people. One of the things that we must learn to do this year is that we must continually tell other people about what you have benefited from today. And for that, I say have a wonderful Friday. Thank God it's Friday. Enjoy your Friday and see you when next we call on you. Thank you very much.